Good afternoon, and welcome to Rare Disease Day presented by Cord for 2026. We are definitely a day ahead, but Rare Disease Day being on Saturday, we're hoping that people will also be out doing Rare Disease Day activities. Um, I think Bill will do the introductions to it, but I am Durhan Wong Reader, President and CEO of the Canadian Organization for Rare Disorders. And we are so absolutely delighted to have such a great interest in our webinar for Rare Disease Day. And we are looking forward to, your participation as we go into our conference in April, but you'll get more details on that. Delighted to have everyone here. And I'm actually going to turn it over to he's almost a co-host. He's been with us so much to Bill Dempster from 360, and he's going to take us through the agenda for today, and also we'll be moderating the panel. So instructions also to everybody. Bill, over to you.
Thanks so much, Durhan, and welcome. This is a record breaker for a Cord webinar, apparently, in terms of the numbers of registrants. There are over 300 people who signed up for this, and I think that that's a testament to how far we've come in terms of rare disease policy and discussions over so many years. If we keep this up, we're going to have most of the rare disease community in Canada, and certainly the leaders on these webinars, which is just terrific. We're going to talk about accelerated access and how to demonstrate value for 2026 and beyond. And we're going to actually have 4 spotlight presentations, and you'll see one of the through lines throughout both the spotlight presentations and the panel discussions that we're going to have is going to be about celebrating the first year and a half of Canada's rare disease drug strategy and informing what we can do and look ahead for what that strategy looks like 2.0. A bit of housekeeping before we get started, and I've already made this note to some folks in the waiting room before you all joined. If you're not on the panel or called on to join, please keep your microphone and your video on mute. Cord's Angela is in the background, actually force muting and turning off your video. So don't be surprised if you pop on, but then you pop off. But please do it yourself, or just don't do it in the first place. That said, use the chat function and the Q&A panel below to throw your questions and comments in. This should be very interactive. If we have time, we certainly will maybe even call on you, as we do in any Cord webinar or meeting. Durhan is known to say, "Hey, I see Matthew out there. I know you have something to say." So that might actually happen a bit later. Speaking of that, we have an hour booked for this meeting. However, we might go just a little bit over time. The good news is that it's recorded on YouTube, so if you have to step off at 1 p.m. Eastern, that won't be a big deal. You can catch up with us later. Yes, it's Rare Disease Day tomorrow, and it's a moment for many of us to recognize the challenges that people living with rare diseases face, but also the real positive momentum that we're finally seeing across so many avenues, from research, care pathways, to access to treatments. Gosh, there was that article I shared with you this morning, Durhan, in the Globe and Mail, about a young boy who got access to a gene therapy that was potentially only available in Montreal at Saint Justine Hospital. But he got on that clinical trial, and he may live a longer and certainly a better quality of life because of it. We want to see many more of those stories that are Canadian in nature, where somebody can get treated in Winnipeg, even if they are from the far north or Newfoundland. That is the Canadian story and dream that we're aiming for. So today's conversation is going to bring together a number of amazing experts and clinicians, families, innovators, and we're going to look at what progress looks like now and what it needs to look like next. So, overview of the agenda. We're going to have 2 parts. The first is going to be spotlight presentations. There's 10 minutes each max. They're going to highlight progress that have been made in 2025 and some of the emerging access pathways. The second part is a panel discussion, and that's about looking ahead and how to extend that rare disease drug strategy and accelerated access into 2026 and beyond. And who knows, maybe one day we're calling it the rare disease drug strategy. Maybe it'll be the rare disease strategy at the national level. But we'll see what the panel says. So the first spotlighter is Dr. Leslie Sorrell. She's managing principal at the Institute of Health Economics, or IHE, in Edmonton. And Leslie is going to talk about the visible and hidden cost of rare disease, drawing on some work actually that people who are logging on right now really contributed to last year. I mean, if you filled out that survey and it took you 20 minutes to an hour, thank you. This is not for naught. This is what Leslie's going to present and talk about, and that was through Ipsos. But the Institute for Health Economics has done some amazing work crunching those numbers and talking about the socioeconomic burden of rare disease across families, health systems, and society. Our second spotlighter doesn't need an introduction because she kicked off the webinar. It's Cord's own president and CEO, Durhan Wong-Rieger. Durhan is going to talk about Canada's rare disease drug strategy and what's working, and really a focus on continued momentum and why that matters, and linking outcomes and real world value to that strategy. And that's a really good bridge to our following, our third spotlighter, who is Dr. Rebecca Marsh, also from the IHE in Edmonton. She is Senior Director of Strategy, Innovation, and Outreach. Rebecca, you know more than almost anyone in Canada about evidence-informed access networks, and you have playbooks that you presented at the past Cord. But let's talk about, are they starting to actually take some bite and work, and are people using them, and how can they be used more? Our fourth and last spotlight speaker is Dr. Sandy Sadev. Dr. Sadev is medical oncologist and assistant professor at the University of Ottawa. He's also co-chair of the Cancer Clinician Advocacy Forum, or CCAF, as we like to call it. Sandy is going to give his take on a few of the emerging pathways that have been put into place currently as pilots. One is Ontario's FAST program, and the other is the Pan-Canadian Pharmaceutical Alliance's expedited negotiations pathways. So we're going to talk about how they're working so far, what it means to cancer patients, and I'm sure this group is going to say, "Hey, why shouldn't it also work for rare disease, the rare disease community?" Our expert panel after the spotlighters is going to come together all together, and we're really fortunate to be joined by Mitch Mineo, a former Assistant Deputy Minister with the British Columbia Department of Health, Dr. Jennifer Adams, a parent and family physician in Ottawa, Dr. Zubaida El-Baldawi, who's a patient and medical resident in Toronto, and Rebecca, you're going to be able to come back and hang out with us on the panel. So that'll be great to get you and back there. So I'm going to pass it over to our first spotlighter. Leslie, over to you. I'm going to mute my video. You've got 10 minutes. Go.
Thanks so much, Bill. Can everybody see my slides? Just thumbs up real quick.
Yes, we can.
Excellent. Okay, so thank you for that introduction, Bill, and thanks to Durhan and Cord for this opportunity to present today and help level set a bit for the webinar as we mark Rare Disease Day together. Now, as mentioned, my name is Leslie Sorrell. I'm a health services and policy researcher and managing principal at the Institute of Health Economics. And over the past few months, I've had the great privilege of working with the Cord team to not just help analyze these survey data, but really help unpack this rich survey data set and help ensure that the stories within it are amplified and meaningfully heard. So with that, actually, before I begin, I would like to acknowledge that I am speaking to you today from the Treaty 6 territory as the traditional and ancestral lands of the Cree, Dene, Saulteaux, Nakota Sioux, and Blackfoot peoples. This territory is also home to the Métis settlements and the Métis Nation of Alberta, regions 2, 3, and 4. And I offer that acknowledgement with respect, recognizing the longstanding resilience of Indigenous communities and the importance of ensuring that experiences of health inequity are seen, are heard, as well as addressed. So with that in mind, today, as mentioned, I'll be presenting on some of the key findings from the Cord Canadian survey that help illuminate the broader socioeconomic impact of rare disorders in Canada. And for those of you who may not be familiar, the Cord survey provides one of the first comprehensive national views of the rare disease lived experience in the country. So this body of work really reflects a collaborative effort led by Cord and supported by the committed partners and funders that are featured here on the slide. And importantly, the insights I'm sharing today are only possible, as Bill mentioned, because of the individuals who generously took the time out of their busy days to complete the survey and share those experiences. So I assume many of you might be on the call today, and just another thank you to you all. Now, very briefly on the methods, this slide was kindly provided by Derek Brazier and the Ipsos team, who led the survey administration, the data collection, and the initial analysis. And we were fortunate to partner with Ipsos, a global leader in survey research and public opinion insights. The Cord survey dataset includes information from 205 respondents who identified as either living with a rare disease or serving as a caregiver. And then to enable comparative analysis of this data set, we also drew data from one of the Ipsos Omnibus surveys, which includes 1,000 respondents from the general population. And specifically for today's talk, we focused on a subset of 464 respondents in that general population sample. So those folks specifically reported having no major health condition. So now, when we think about the framing of socioeconomic impacts, and we talk about this phrase a lot, we often most are drawn to the concept of cost specifically. And I think when we consider cost in the context of health, we first turn to health system encounters, such as physician visits and trips to the hospital. These are the most visible types of costs. And they're often primary outcomes in trials, they're collected in our administrative health data, and they also show up in our public budgets. But as you can see here from this image, these types of costs only reflect part of the picture. And as we know with rare disease, many costs are often quietly absorbed by patients and their families in terms of time, effort, and personal expenses. And these are those somewhat depicted in the light blue here. Now, they can be considered more as hidden costs. And while they don't appear in public budgets, they do carry a significant toll on families' financial securities and quality of life. Now, with this survey, we're able to examine both of these cost domains within a single national data set and framework. This allows us to see a fuller scope of the socioeconomic impact of rare disease. So let's start with the visible or health system costs that we collected in the data from the survey. And we can start here with looking at annual visits to the family physician. In both the Cord and general population survey, actually, respondents were asked how many times did they see their family physicians in the past 12 months. So to help orient you a bit with this slide, these big gray boxes, they represent all of the respondents who answered this question. So for the two surveys, the Cord survey is depicted on the left. So as you can see here, the lighter purple boxes now show the proportion who reported at least one family physician visit in the past year. And the darker blue boxes represent those who reported 3 or more visits. So for those with rare disease, there is very high engagement with primary care relative to the general population. 94% of respondents specifically had at least one visit, and more than 60% had 3 or more visits. When we translate these into costs using national cost estimates, the average annual cost of family doc visits was roughly double that of individuals without a health condition in the general population. So looking across the continuum of care, we actually see that this pattern persists. So again, when compared to those with no health conditions in the general population, the annual costs for specialist visits for individuals with rare disease were roughly 7 times higher. For emergency department visits, they were 4 times higher, and for hospitalization, the costs were roughly double. So it's apparent there are substantial visible or publicly borne system costs. But what about the costs that I mentioned that we do not readily see? So from the Cord survey, we found that these hidden costs for rare disease were quite marked, with about 73% of respondents reporting that they paid out of pocket for expenses related to their care. So that's nearly 3 in 4 individuals and their families. When we examine these types and the magnitude of those personal expenses, we found that on average, respondents reported more than $6,000 per year in out-of-pocket spending. And in some cases, respondents' maximum financial exposure reached tens of thousands of dollars annually. And I do want to highlight on the slide the prescription drug spending, as this is one of the areas we were able to directly compare to data reported in the general population survey. And as we see, the average prescription drug spending among the rare disease respondents is about 10 times higher than for those without a reported health condition. So, taken together in uncovering these costs, we're better able to comprehend how they might translate into real household financial strain. And this strain actually was quite reflected in the words of one caregiver respondent who reported that after many years of getting diagnoses for the symptoms of my child's disorder, we finally got a proper answer to the reason behind all of them. The impact of this rare disease on our family is enormous on all levels. Our child's health and quality of life, our physical and mental health, our finances, and social lives, and more. So now, interestingly, in that quote, the caregiver surfaces that notion of their child's diagnostic odyssey as well. So that's the prolonged and often nonlinear path to rare disease diagnosis. And when we examine the CORD survey data on diagnostic histories, so from first symptom onset, we also saw that this odyssey was substantiated quantitatively, where more than half of the respondents, so 53%, reported experiencing at least one misdiagnosis. And among them, the average number of misdiagnoses was 5. And in this time frame, so from symptom onset to confirmed diagnosis, respondents also reported having repeated physician visits. So on average, 7 to a family physician and 7 to a specialist. And there we go. So lastly, we also examine whether a diagnostic delay was associated with greater personal financial exposure. And what we found was that when diagnosis was delayed by 5 or more years, so that is if the time from the first symptom onset to confirmed diagnosis was greater than 5 years, the reported average out-of-pocket costs related to care were approximately 1.5 times higher compared to those who were diagnosed within less than 5 years. So a delay to diagnosis can therefore represent not only a clinical issue, but also an economic one, as it compounds both the visible and seen here, hidden costs for rare disease. So, in closing, through this brief snapshot today, I hope you were able to see that the CORD Canadian survey findings help bring into focus the layered and really substantial impact of rare disease. And in doing so, I think this really reflects the core purpose of Rare Disease Day. So making the unseen visible. And with these messages that I've shown here on this slide, I think a key takeaway I want to leave with you is this. If we only measure what is visible, we not only risk underestimating the true burden borne by individuals living with rare disease and their families and their caregivers, but we also risk overlooking where inequities in access and therapies and quality of care may really deepen. So with that, I will bring it to a close, and thank you again for your time.
Thanks so much, Leslie. That's a great way to kick it off with very high impact data. And I'm going to hand it over to Derhan, who's going to walk us through what's happening in 2025 with the rare disease drug strategy and some ideas for what's next that's going to drive the next discussion. Over to you, Derhan.
Thank you very much. I just need to make sure I get the right slide up here. Okay, so I'm just going to give you an overview of hopefully what a lot of you already know, and that is we've been living with the actually the fruits of a rare disease drug strategy and where we are now, and as Bill says, and where we feel we want to be going in the next short time. So many of you hopefully will have seen this slide. This slide indicates, we, at the announcement of the rare disease drug strategy, and we were there side by side with the minister when it was announced. And these are the objectives of it. It's a 3-year strategy, basically to increase access to, affordability of effective drugs for rare diseases, which will contribute to improving the health of patients across Canada. Leslie didn't talk about the delays in access to medicines, but as many of you will know, there's a very long delay in getting access to drugs even after they come to Canada, which may actually lag that drug being available in Europe or in USA by many months and sometimes by many years. The other thing that was very important that was said is that we will take the lessons we're learning from this strategy to incorporate into future phases. We think meaning future phases of the strategy so that we can keep the government aligned with broader pharmaceutical agendas. So I won't go through all of the objectives, but it really was to improve outcome sustainability, improve the national consistency, collect and use evidence, invest in innovation. And those were actually what the government said. So we're very excited. So here we are 18 months later. The question is, what has been achieved, and are we realizing the promises that were made, the objectives that were laid out? Well, the answer is, of course, somewhat yes and no. The strategy, $1.5 billion, will actually expire in April 2027. It took about a year for the federal government to sign deals with the provincial governments. So many of you will know is that $1.4 billion went directly to the provinces to help pay for rare disease drugs, but also to address many of the promises that were made. So what have we seen? Well, we're about halfway through that 3 years. So first 1.5 years of the rare disease drug strategy, and we are seeing measurable progress in drug access. I'll give you a real quick snapshot of it in the next few slides, but it's happening. Government said, here are drugs that are going to go on a common list across all the provinces. They said 12. We only know of 9 so far, but we will be able to see that of those 9 drugs, we are seeing real progress in terms of getting access and being able to make them more equitably available across the country. What we do want to emphasize, though, is that we've got 1.5 years left in terms of that strategy. We're waiting for the evaluation report on that first 1.5 years, which federal government has collected information from the provinces on. But we want to say is that we have to demonstrate what was the value of that access. We got faster access, but what does that mean? Has a measurable impact on patient outcomes? And maybe to a bit of what Leslie was saying, has it also improved in terms of patients being able to not only rely less on the rest of the healthcare system, but also have they been able to demonstrate better quality of life, reduce, personal payments in terms of other supportive care and other healthcare services. And very importantly, what happens after 2027? I don't think anybody would suggest that $1.5 billion, as huge amount as that is going to carry us through the lifetime of, rare disease access. So we have said, and as they say for the next phases, we need to, as a community, collectively prepare for phase 2. And we have to see in that phase 2 what I'm going to give a small hint to, but what we want to spend the next year really talking about with all of you in the community, the same as you talked with us before phase 1 came in. What do we have to invest in? And what else do we need to do to achieve equitable outcomes? Just a quick snapshot backwards. You can have this slide. You don't need to look at the details of it. What we will say is that, these drugs have gone through, we think, at least from the PCPA to getting access to patients a lot quicker. What has been, and you can't really see it exactly in the numbers, but what we know has happened is that these are drugs already approved by Health Canada, already recommended by CDA or INESS, or then going to the Pan-Canadian Pharmaceutical Alliance to get negotiated for a price. The big difference, those times are still there if we look at them. They're still long. In fact, you can see how long some of them are. 2,026 days from the time Health Canada said go to the time it actually gets onto a provincial formulary. The best one, of course, is the one for Eplinthill, which actually came through in 341 days. But most of these are still around 780, 800 days in order to get to patients. We have to do a whole lot better. But what we do know is a real advantage to this is that once they got picked up by the PCPA, most of them went immediately onto formularies. And we're hearing from patients, we're hearing from healthcare professionals, we're hearing from even the farmers who are saying, yes, we've got them on there. And this has been a real advantage of having the monies given to the provinces who can say, okay, we can put them immediately on access lists to make them available to patients. And that's not trivial, it's huge. Some of the other things we can talk about later. So this is what we've got. The timelines are still long. The negotiated discounts have still had to be substantially big, 75% discounts on average, but it's moving. And we have to recognize this. The timelines are shifting. We're seeing patients getting access. We're seeing these drugs come in. And this is just a very quick snapshot. Do we have more equitable access is the question. That was one of the goals. Yeah, okay, there was a list of 9 drugs. And in fact, what we see is that all provinces have picked up the common list, except for Quebec, which is obviously doing some other ways of bringing these drugs on. 4 of the provinces have listed all 9 drugs. That's a huge asset. And of course, we're knowing that, as I just said, we're getting them to patients almost immediately after the agreements. So national coordination is improving, but we don't really know how this 1.4 billion is being allocated or spent provincially. The provinces got huge amounts of monies, as you can see on there. 194 million for British Columbia, 535 million for Ontario, etc. So it's a large chunk of money. Some of it obviously going to these drugs, but what else is being done in terms of addressing the other objectives, and what else is being done to demonstrate the drugs are working as they should and delivering value? So what we know that accelerated access is necessary, but it's not sufficient. As you can see here, and as Leslie indicated, as patients will, it takes a long time to get to a diagnosis. So we need to improve that. If we can't diagnose the patients, we can't give them access. The referral pathways are long and convoluted, as you heard from Leslie. So if we can't get patients referred to the right specialist, they're not going to get access. We have limited specialist expertise in many of these areas still, and they're oftentimes located in key centers, which doesn't serve well for patients. So in terms of needing to have some form of a hub and spoke model, the therapy has to be initiated in a timely fashion. Structured follow-up. You can't just give out a drug. We know that the clinicians are following up. They're not just handing out drugs. We're not collecting the data. We do not have systematic data collection. Even for these 9 drugs across the provinces, we have to do that. We have to demonstrate how they're working, how well they're working, and in fact, if they're not working in the ways that we expected. So we have to have investment in real-world evidence collection. So without that, we cannot demonstrate the value of these therapies, the value of the 1.4 billion that's gone to the provinces. So this takes us back to where we started from. And Bill, who was with us at the very beginning of this journey, and many of you as well, we, 10, 11 years ago, proposed Canada's rare disease strategy, as Bill said, not just the drug strategy, with 5 key pillars on it, which I won't repeat except to say we have to make sure that we're actually addressing all 5 pillars if we want to make a real impact. So today, with the rare disease drug strategy, we have addressed pillar 4, providing sustainable access to promising therapies. Well, at least we're providing accelerated access. Hopefully it's sustainable. We hope that some of the monies that are still there from that $1.4 billion investment will go into pillars 1 to 3, early detection, timely, equitable, evidence-informed care, that we're able to also invest in much more innovative research so that we're developing therapies in Canada. The strategy then has committed to, what do we have? Always follow up. Collecting use evidence. Well, okay, we haven't done that really well. Support sustainability. We haven't really done that well. What we need then is at least 4 things. Transparent national framework for outcome tracking, public provincial reporting on utilization and equity. What is happening to it? Who's using it? Is it getting to all the people? Increased visibility on real-world effectiveness, And as we say, only with this follow-up will we have proof of the value of what we're already investing. So phase two, I want to say, from a drug strategy to a rare disease system strategy, we need to make sure the federal government is investing the monies, but that we're also then going to be investing in phase two, follow up in terms of the monies that are going out. And in order to do that, we have to have a system. And that system will support not only demonstrating the value of the drug therapy, but the whole improvement from diagnosis all the way to informed managed care. So we're still advocating for rare disease drugs today. We're still advocating for a strategy. Hopefully we're not going to be out there in the cold again doing it. But as you know from the patient community, if we need to, we will be. Thank you very much.
Terrific. Thanks so much, Durhan. And just to let you know, I threw the WHA resolution on that got passed at the global level last May. So maybe we'll come back to that because it calls on jurisdictions to implement national action plans that I think build on exactly what CORD launched in 2015. Rebecca, over to you. Let us know a few things about how we can do this to make it actually work in practice, please. Thanks.
Thank you so much, Bill, and thank you for this opportunity to speak with you all today on this very important recognition of rare diseases. And so, like Leslie, I am joining you from Treaty 6 territory, the traditional lands of First Nations and Métis peoples. I am grateful to live and work here and to be able to contribute to these kinds of conversations that are ultimately about equity, care, and access, as we've heard from both Leslie and Durhan. And so I want to move us into something very practical, how we make access decisions in rare disease and where there are still opportunities to do things differently, to adapt so that we can ultimately improve outcomes for those living with rare disorders and their families and communities. There are more than 7,000 identified rare disorders. So when we talk about rare disease policy, we're not talking about a rare issue. We're talking about a very large and diverse landscape. 5% have an effective therapy. For the vast majority of rare conditions, there is still no targeted treatment available. Of those therapies, 60% go on to receive Health Canada approval. That reflects strong work by the manufacturers and regulators, and it is often under challenging evidence conditions. And then only 25% of those go on to be listed by public plans. Each step in this pathway is rational, right? The decision-making is based on the evidence that we expect with more common conditions, but together this narrowing is significant. So our system is designed to move in a linear way overall. We expect strong clinical evidence to establish safety and effectiveness. This is important, and that evidence goes on to inform assessments of value as well as price. And the coverage decisions made in what to list, what not to list, are made based on demonstrated value, right? So demonstrated value, when that evidence is robust and patient populations are large, we can do clinical trials, and this pathway works well. But rare disease therapies and rare diseases often enter the system differently, right? By their very nature, there's small sample sizes. There's often limited comparators for these types of therapies and for these types of conditions. And there's often a lack of long-term data. And we're really fortunate that more and more of these therapies are coming into the pipeline. But again, with this limited evidence, as well as these small sizes of patients, these therapies often come with high costs as well. And so this linearity in terms of most of our processes is being strained. And as we've seen in the past two presentations, the result is often delayed, denied, or inconsistent access. And so our response is not to abandon this traditional model, right? It works really well for a lot of our therapies and for more common conditions. But we also need to consider where we might need to adapt it further. And this is where designing access in a way that continues generating and using evidence becomes extremely important, and it's an opportunity. Durhan talked a lot about we have a lot to learn. We need to continue to learn, and we need to do that within the process as well of providing access and making these types of evidence-informed decisions. So access becomes part of a process, not the end of it. So this example of access with evidence models, rather than evidence before access, can be seen in quite a few of our innovative listing models that we have, both nationally as well as internationally. And here's just a few examples. Coverage with evidence development, so we can link access to structured research. We can have performance-based agreements where payment is linked to the outcomes. We can have milestone-based agreements, payment aligned with the delivery of value over time. And there's also appropriate use agreements where really we want to match the right patients to the right therapy. So these are tools that we have, policy tools, access tools. They're not appropriate in every case, but they can help manage the uncertainty that is inherent with a rare condition and with a therapy that supports patients with these conditions. So these access with evidence models can help manage uncertainty in certain contexts and not have to wait for the evidence to be fulsome before we make these decisions. And so we tend to see these approaches being most useful in a few patterns that we call archetypes. So the one-shot curative therapies, where you can pay a lot up front, but you could have transformative lifetime outcomes. There are breakthrough new therapies that can extend life. And with these breakthrough new therapies, there are often a lack of comparators. There's also disease-modifying therapies for more complex chronic conditions. And then there are other where there are conditions that have a highly variable response to a particular therapy. And then finally, there are opportunities to repurpose existing therapies in new ways and in new conditions that are potentially underserved populations. So these aren't rigid categories, but this shows the breadth of opportunities that we have for better supporting patients with rare disorders, and to see where some of these signals are for where these multiple factors come together to strain current structures, but also provide us with an opportunity to think differently about how we work together. And this is the most important thing here, is that we need to commit all of our communities and interest groups involved in making these decisions and ensuring appropriate access. We need to come together and be willing to make decisions differently. We need a shared commitment to continued learning, to being adaptive, and to making decisions under persistent uncertainty, and getting comfortable with that. Second, we need, of course, trust and transparency wherever possible. And this is in particular around data governance, but as well as outcomes. And the data that is being generated through these types of agreements and being used in order to not only contribute to the greater evidence base, but also to making these decisions better. And a big part of that is trusting patients and the patient experience in terms of what does the best outcome look like. And finally, we need practical guidance. So we need structures, we need processes, we need playbooks on how we can work together differently across all of our interests in service of our patients. And so one thing here to just highlight is we do have an outcome-based agreement playbook that we've developed that is freely available online, and we encourage you to leverage that wherever possible within your work. And so ultimately, access with evidence is about balancing three imperatives. Patients need timely access. Innovators need predictable pathways. Systems need sustainable models. And the challenge in rare disease is that these pressures are intensified, and this structured learning, this access with evidence, can help us navigate these tensions more deliberately in ways that can work for all of the interest groups. And so I want to bring us back to the caregiver quote that Leslie started at the beginning of her presentation. And further down in this particular quote is a reminder of all of those interests and imperatives. And so this caregiver continued on to say, the importance of diagnosing individuals and supporting proper care, research, and therapeutics development cannot be overstated. And that is the reminder behind all of this, is really, this is ultimately about people. It is about our Canadian patients and how we can collectively adapt and do things differently in order to ensure the best possible outcomes. So thank you, and I'm happy to continue the conversation.
Thanks so much, Rebecca. That was terrific, and a nice way to bring it back to what Leslie presented in terms of some of the quotes and the qualitative input that came in from hundreds of Canadians were affected by rare diseases across the country. So thanks to you on the line as well. Dr. Sadev, tell us a bit about your perspective on these faster or accelerated access pathways, especially for oncology medicine, and we're going to figure out how to get those online for rare diseases as well. So over to you. Thanks so much for joining.
Yeah, thanks. The good thing about being the closer is I get an excuse to go a bit faster, so you don't have to hear me quite as long. Can you hear me, Bill, and see my slides?
Yeah, looks great. Thanks.
So I think the one thing I was thinking of during those great presentations was, what does cancer have in common with rare diseases sort of structurally? And the two themes I thought of are, one is, cancer, we're dealing with, like with many rare diseases, with truly, rare, uncommon, but also life-threatening and life-changing disorders that need urgent attention. And the other thing from the cancer perspective is, now because of precision medicine, even common cancers like lung and breast are being subdivided into baskets of individual subtypes that qualify numerically as rare diseases, and the governments are upset that everything seems to be a rare disease. I'll be talking from the lens of like 35 years in practice, 41 years since my first oncology rotation, and the changes that I've seen and frustrations that we've had as clinicians. So first of all, the CCAF is something we launched about a couple of years ago, and it came up because so many clinicians across the country were contacting me and saying, we're at a point now, as a breaking point, where we can no longer treat people optimally, because all the newest things that are proven we're not able to get, diagnostic testing, molecular testing, how can we put our voices together? So we now have about 26 clinicians. It's not just physicians, leads of nursing leadership in oncology, pharmacists in oncology, and from every province and from every English and French backgrounds. That's where we're coming from. This year, our main focus will be on diagnostic testing, including precision medicine to identify rare subtypes of diseases, faster access to medications, and some of the efficiency and human resource problems we're having. So, like I think you've heard before, for many common medical conditions, the problem with cancer care now is not that we're not having amazing breakthroughs coming through, a tsunami of them, but there's about a 2-year delay between evidence and an access decision, even if it's no often. And that wait, my colleague Dr. Stewart has quantified how many patients die simply because of a delay between the evidence and the access decision that could have started therapy before. We're at least a year longer than our peer countries, as you well know, in the OECD and the G7. So I want to talk a bit about the Ontario processes going on now. As it turns out, my nephew is now on Doug Ford's PR team. I was involved a bit with media work on Rob Ford's cancer and education on cancer systems back then. I think he's been truly motivated to try to make things better. So this FAST program, Funding Acceleration for Specific Treatments, came out, I think, because of a recognition of the problems we're having in cancer. The idea was to fast track funding for 7 to 10 high priority drugs. We have issues with how they define high priority. They have to go through Project Orbis, which is an international collaboration of regulators to help speed up processes somewhat. Some drugs don't go through Project Orbis, and that's a problem we'll talk about. But on average, we could save up to a year in access time for our patients with this process going through. The pilot involves funding of drugs much earlier, before PCPA price negotiations, to give more immediate access. So the drugs that have been treated or approved so far through this process, I've highlighted a few here. Of the 5 I've listed, I think there's a couple more since then. 4 of these are orals, just by maybe coincidence. The Nivo-Ipi in the bottom left is a drug combination of immunotherapy we've had for quite some time, but in new indications in liver cancer and a certain kind of colorectal cancer. But these have been much appreciated by the treating communities and patients. What does the earlier access mean to patients? So, if, for example, I no longer treat lung cancer, but if you're a lung cancer patient, about 15% have a particular driver mutation. Now you can have access to this oral drug that's well tolerated, that after curative surgery can prevent or dramatically delay incurable metastases, so saving lives, and they can get it earlier in their treatment journey, not as a later line, so they have less toxicity and longer duration of benefit. For all of us, it reduces anxiety and uncertainty. Our patients are well informed. They want the best treatments. It improves equity to avoid, barriers between insured and non-insured patients. It empowers oncologists to do our job with less red tape, taking up our time and getting reimbursement through private insurance, and it can improve outcomes for society. Patients are working. Patients are generating tax income for governments. They're meaningfully contributing to society when they're on these better medications. So the process is really meant to streamline things with the FAST program. We have Health Canada approval and CDA, which are now more aligned than before. We then have FAST interim funding. Then it goes on to PCPA, and there's a listing by manufacturer. One thing we're working on through CCAF and with CanCertainty and patient coalitions is, why is there a variable delay between the provinces from PCPA agreements to listing? That can range from 44 days or less in Quebec to almost a year in other provinces, just because of bureaucratic delays. One little critical safeguard built into the FAST program is that if a drug does not succeed eventually at PCPA, the manufacturers are required to cover the treatment costs for patients who have already started therapy. So this is a kind of a risk-sharing thing. And I don't understand all the details yet, but based upon some of the European models, when PCPA negotiates the price, they should be estimating how much has been spent at list price and maybe clawing that back, at least in relative terms, in the final negotiated price, so we don't end up spending a lot more. The ENP is a fast-track program by PCPA, the Funding and Reimbursement Negotiating Authority. And we're not really clear if this early negotiated process, ENP, was a reaction by PCPA in response to the FAST program, thinking like, they're getting ahead of us, we're not pulling our weight, we have to do something as well. The two programs are operating in parallel. The key difference that the FAST program facilitates reimbursement before PCPA, with the caveat that the innovator will reimburse otherwise. But a little bit different, it is possible, as quoted in Globe below, that if the ENP fast tracking through PCPA works effectively, there may be less need for the FAST program later. So the ENP, as it mentions in the bottom right, is intended to reduce the negotiating timeframes now, which are all beyond PCPA targets, by several months, by starting negotiation processes before the final HTA reimbursement recommendation has been issued. So before the CDA, they start the negotiating process, because the vast majority of cancer drugs are eventually approved through PCPA. So it should really speed things up. This graphic is from CGI. I asked the computer to generate a graphic of a clinician and administrator running fast together. Our goal is really to help the system recognize that rare diseases are often urgent, cancer is urgent, And we cannot be operating at a government bureaucracy time, 9 to 5, go home early on Fridays. We have to operate on COVID-19 time. We have to recognize the burden to life and limb, the threats of these diseases. So this program should dramatically reduce waste times. It should help us align with global best practices, provide better patient-centered care, and even be an innovation catalyst if innovators see that there's a process to help get their drugs to patients more efficiently and in a more predictable pathway. Challenges, well, we have this problem where it's restricted to Project Orbis. The pharma companies decide what goes through Orbis. We were frightened with Trump that Orbis might stop. It's FDA-led. Project Orbis sometimes slows down cancer drugs for Americans, unfortunately, so there are some threats to that. Complex therapies are excluded. Things like CAR T that are very complex, require a lot of infrastructure for adoption, are not currently included, and they're major breakthroughs in many hematologic cancers. There are communication gaps. Many clinicians know nothing about this process. For several of the oral drugs that first came out, doctors weren't even aware they were funded after the funding came through. And of course, there's sustainability concerns. It's not just that we're approving things more quickly. I'm not that worried about the cost impact of this process because, eventually I think we would have spent the same later, just sort of speeding things up to get us access earlier. But the absolute number of new breakthroughs coming through is going to pose sustainability challenges. And we're all afraid as oncologists, we may be moving one day to a two-tiered model of care, unfortunately, or partially to a New Zealand kind of system where governments will just say, look, we just can't afford these things and the benefit is too small for us to pay. So we'll have to see how that goes. Opportunities, I've already hinted at these. Expand eligibility as we get our feet wet with FAST to include more cancer types, innovative types of therapies, maybe go beyond Project Orbis, that people can agree a non-Orbis drug is extremely urgent and important. I have two number ones by mistake here, but we should have more of ongoing pan-Canadian collaboration. PCODER initially was a provincial Ontario thing called JODER. The other provinces joined on as observer status before they joined in to make it PCODER. We've asked provinces now to take an official observer status to FAST to help them perhaps emulate or join that program nationally. This was highlighted on by the previous speakers. We need to collect real-world evidence. Canadians are very collaborative. We have a relatively small number of centers. We can get our EMRs together better to collect this well, and we can really inform both nationally and globally the value in place and therapy of treatments. So the future, I think the provincial model in Ontario hopefully should be a template for other provinces. We've done a lot through pan-provincial collaboration to avoid duplication of efforts from small and big provinces. I think we need to stretch this model beyond oncology. We recognize that rare diseases also pose threats to life and limb. They're extremely, complex conditions and require a similar framework. We need better digital integration to collect real-world evidence. And I think, as Durhan mentioned, ongoing dynamic evaluation of the efficacy, cost-effectiveness, using properly collected data, including the hidden costs. So in summary, I think we've already seen proven results with much faster access. They've proven this in France and in the UK. In France, they were actually getting access before America through earlier fast-track programs for cancer. Clinician advocacy will be a critical thing. I hope CCAF can spark more of that to get our voices heard. There is room to grow with expansion beyond just Orbis and beyond just cancer. And I think this has to be a shared commitment where all of us involved in cancer and rare disease care work together to make our voices amplified and delivered loud and clear. So the call to action, let's engage everyone together. Let's advocate for inclusion, support data-driven evaluation, and maybe Ontario might take the need nationally, but let's do this all together, get other provinces on board so we don't have to waste time. I'll wrap up by just reflecting again on my 35 or 41 years. This process is long overdue. We have had these problems since paclitaxel, the first expensive chemo drug, $5,000 a dose back in '92. When that first came out, we've had these problems, and the procedures, the performance standards expected of government have not really improved, and actually they've gotten worse. Doug Clark mentioned at our grand rounds before that if anyone had to design the systems we have now No one would have designed it this way, with processes, steps bolted on decade by decade that have been very rigorous and high quality, but have made everything worse in terms of timeliness. All of this process with FAST is one piece in the puzzle. We are suffering because of lack of GPs, no ultrasounds or CTs. We have fewer per capita than Chile or Turkey. Delays in workups. We have fewer specialists in Canada than GPs per capita. So our system right now is really struggling, and we have to have a holistic view to healthcare to make all this work. The cost, I'm not that worried about. I don't think it'll necessarily be higher, but the total absolute costs are going to be daunting as we have so many new therapies coming through. And again, this is a national issue. Let's get the other provinces to take a have meaningful input and participation. So I'll stop there and hope I wasn't over, but Bill?
Thanks, Sandy. You weren't. That was terrific. And observant participants will have noticed that 4 of the 9 medicines that are on the common list are in fact for rare cancers. There's von Hippel-Lindau disorder, there's lymphoma there, et cetera. So rare cancers are part of the rare disease drug strategy already, Sandy. So the question is, and I think you posed it, and I'm going to welcome the panel on, and thank you, Sandy, for your time. Stick around and contribute through the chat and other means. Can we get these accelerated access pathways online as part of Rare Disease Strategy 2.0? We're going to go through a few different themes there, and I'll turn it over to again to Rebecca. Welcome, Dr. Jennifer Adams. Looking out for you to come in. Dr. Zubaida El-Baldawi is also going to join us on the panel. And of course, Mitch Moneo, ADM, former ADM from British Columbia. Mitch, if you were still ADM, I'm sure you would not have been able to join us for an extra 15 minutes because we are going to go overtime on this panel today. So come on, unmute, or at least come on for with your videos, because Rebecca, you and I are just getting lonely here, aren't we? Where are other panelists? There we go. There's Mitch. Excellent. Great to see you. Dr. El-Baldawi, are you joining us as well?
I can't. It says unable to start video. Since host disabled the video.
Oh, okay. Well, the host with the most,
It
also
should
known
be
as.
able to do it now.
Excellent. Right on. So I want to just start with, what is the reaction of the panel having heard the spotlight presentations? Maybe we'll start with you, Mitch, because you were, involved at the provincial level in contributing to and getting the bilateral in place for British Columbia and its involvement. What's your reaction having seen this now implemented in the first year and a half, and some ideas of what could happen next?
Yeah, thanks, Bill. I was in quite a few detailed discussions with the federal government when the framework for the strategy was being designed, and I've been following it quite closely now, even though I've retired, and I've got quite a great interest in on the way this is progressing. I think some of the comments that Durhan had made earlier around access, increasing time to access have been accomplished to some extent. I mean, I think removing the financial and considerations for public payers like those in British Columbia and other jurisdictions have sort of alleviated or mitigated some of those more complicated decisions that have to be made when we're looking at funding. I know that coming over the next year and a half, I think one of the things that I'm really looking forward to is the evidence collection work plans that are part of the design and the framework of that agreement. I'm not sure where they are at this point. I'm a little bit concerned because I was at a recent CHR conference, and they had spoken about they had the PCPA, Mauro Cheese from the PCPA there, and he spoke about the application, I guess, of outcome-based agreements, what the stuff that Rebecca was speaking of, and he was saying that although PCPA has an interest in those type of agreements, they really don't see the practical application currently because they don't know who's going to track and who's going to deal with the collection of that evidence. So I think it's going to be critical going forward to get a better understanding of what those work plans are all about and how they're going to kind of work with all the other partners that are involved. I mean, I think that CDA and CIHI and others have all made strides too. I mean, I think the work that CDA is doing, the framework was an impetus for the CDA to do their screening and diagnostic work and also their patient registry, their rare disease registry work that they're doing. I mean, it's still fledgling, but I think it's progressing, and I think CIHI has also been doing a lot of work. So I think there's a lot of exciting things that are happening, but I think going forward now, I'm interested in how this is going to come together and what the practical application will be. And the reason I say that too, just quickly, is that we're dealing with a time where provincial and federal budgets, there's a lot of austerity now and a lot of uncertainty because of the geopolitical situation and everything else. And I think that the key to this strategy is to demonstrate value, because I don't know if we can always, provinces and territories can always rely on the federal government to be subsidizing, some of the costs of some of these drugs. So the key is to use what we have today, build on it, demonstrate that there is value by collecting the evidence and maybe doing some pilots or whatever, so that all the payers are comfortable going forward and continuing on with the work that's already been started. So maybe I'll stop there, but that's kind of where I see the future.
Thanks so much, Mitch. That's terrific. It's a bit of a response to some of what Rebecca talked about in her spotlight presentation in terms of the how it can be done. Some of the folks who will be collecting the data and reporting on the data are clinicians. In fact, you're the ones who are at the right in the clinic working with patients. And in fact, we've got two physicians with us today who have very intimate and personal connections to rare diseases as well. So I want to turn it over to Doctors Al-Badawi and Dr. Adams to just share a bit of your perspectives on what you've seen so far and where you think this can go forward. Starting with your role in the rare disease community, but maybe you could actually respond to some of what Mitch said about, can we actually collect the data about how this is being used? Or maybe start with the newest face on the Cord circuit. So Beta, it's so nice to get to know you, and thank you so much for joining. So first comment to you, please.
Hopefully my audio is okay. We're obviously very junior to all of this, but I think just as you said, from the patient perspective, it's very. I just wanted to comment on the presentations are obviously very fantastic, and also will give a lot of hope into what's happening. But also in the past year and a half that's happened, but just also reading and listening to Doreen's presentation, that we tend to be behind in Canada is obviously something that firsthand experience with access to these rare medications. And in terms of, I guess, to the question or the comment that was made about being able to support registry. So I just kind of disclosure, for me, it's I'm a patient with homozygous familial hypercholesterolemia. So there's a lot of kind of patients, a lot of upfront work in this area from clinicians who have kind of taken on their own initiatives to collect and start the registries and that. So it's a lot of kind of, I guess, the motivation by individuals who are in the field, who are seeing those patients, to collect the data, and it's certainly not impossible. There's a lot of patients in the age of age who are on rare medications specifically, who that are quite expensive, and they're also kind of the tracking for that. Part of what I do with the age of age group is track the access to that in across Canada and the outcomes for patients on those medications. So it certainly can be done. I just think it obviously needs a lot of resource. It is resource intensive, and it needs a lot of coordination across the country to help us track that.
Thanks so much. And just for next time you jump in, if you could adjust your microphone to be a bit more sensitive, I think that would be great. A couple of our listeners were saying it was a bit hard to hear you. Sorry for not interrupting. I think I could hear you, but others couldn't. It was a bit like those old phone-in radio shows where you could tell that they were in a phone booth somewhere, right? So yeah, let's see if we can make some tweaks there. Yeah, Jennifer, over to you.
Hi, if you don't know me, I'm Dr. Jennifer Adams. I'm a family physician in Ottawa, and my daughter has primary hyperoxaluria type 1. And so she is on Oxlumo or Lumasiran, which is one of the drugs on the common list. I'm a family physician in Ottawa, so no, I'm not a nephrologist, I'm not a metabolic physician, but I do have some clinical insights. And then as a parent, that's really where the majority of my insights come in terms of this. So, in terms of what my experience has been so far with the National Strategy for Drugs for Rare Disease, my daughter is on drug, and that has been the biggest change in our life. So, all of what Rebecca has discussed, what Leslie has discussed in terms of those hidden costs, absolutely had huge, large impacts for us. Once she was on therapy, our anxiety settled down, our life kind of turned back into our new normal. New normal is not what normal sort of is for us. We still spend 35 hours a week on managing her rare diseases. However, my husband was able to go back to work. We can live where we want to live now these days. Mental health has improved. All of those hidden costs significantly reduced. When we're talking about what, in terms of the national strategy and where I can see it moving forwards, the biggest concern I have is I'm just not sure how her drug is funded at this point in time. Was it funded through the national strategy? Is it listed with the province? Is it going to be continue to be listed? Like those are the questions that I'm sitting here as a parent in a year. I'm kind of my anxiety and my mental health is kind of like getting worse at this moment in time because I'm not sure, is she going to have access to drug or not? We are fortunate that we have private insurance that currently covers that drug, but we have a maximum that will expire after her next dose, and we will then be turning to the public system, and then we're not sure what will happen after that point in time. If is evidence that you need or people need in terms of to show that this has been life-changing for us and life-changing for many of the other people who I know within the community, well, we're working on it. It just takes time. So I'm also a co-investigator on HopeCan, which is the new registry that was started in part by funding from CDA, so Hyperoxaluria Outcome and Patient Evaluations Canada. So the lead physician is Matthew Lemaire. So we're working together to form a registry and collecting that patient data, but it takes time. We're just like brand new at this. We haven't done this before, so we don't have that data to be able to submit at this point in time. Now, is there anything that we are going to find significantly different that is not available internationally to say that this drug is not working effectively? I don't think so. I can't imagine that there would be anything significantly different for Canadian populations that would not show that that it's not the same nationally compared to the US or compared to Europe. So I'm not sure why that data is not significant enough at this moment in time. That's a question I have. I understand why the registry is important in terms of planning, in terms of seeing what we need specifically for in Canada, but in that very short moment in time when we're still working on it, I don't fully understand what that piece is coming into, although I see long term why it's definitely important. And in terms of showing how in Canada we can be stronger in the rare disease community and innovation pieces. And then what else do I see moving forwards for a national strategy, not just a drug strategy, is what I would like to see moving forwards. Again, because of all those hidden costs that we experienced as a family and within the community we have experienced as well. So those different phases and those different pillars that Durhan has been referencing again and again throughout the rare disease community.
That's excellent. Thanks, Jennifer. And I mean, there are examples of that. We have a cancer control strategy, for instance, at the national level. We've got a mental health strategy. CORD's been calling for a rare disease strategy. Just a quick point about where the money goes, and Mitch, you can thumbs up or thumbs up or down on this. There's a bilateral agreement that carries with it some commitments around investments for all provinces except for Quebec because they didn't want any strings attached. But otherwise, the money goes to general revenues in each of the provinces and territories. And the idea is they report back based on those bilateral agreements. And I see Mitch nodding his head. So we're waiting for that report back. Basically, we haven't seen anything. It's been promised. I couldn't get Health Canada to commit to a time, but April is when the CORD conference is happening. And Daniel and Health Canada, if you're listening, we want the report out by April. Okay. Uh, Rebecca, we talked a lot about data in terms of collecting it, and Mitch put down that sort of challenge. Do you think that in your playbook, does it require patient level data across the country from everyone, or could it look at, say, Alberta's data, if the same clinical guidelines are used across the country, can't we just collect data for how it's working or maybe not working or et cetera in a certain part of Canada? Or even Jennifer mentioned at the global level, like, is there an issue there where we're trying to get to perfection in patient level data in terms of efficacy, or can we do something that would be more surrogate and proxy in nature?
Yeah, it's a great question, and I think oftentimes these conversations end up converging on data, and I always feel data and outcomes, and I always feel like this tremendous weight that we place on this data and these outcomes is just it's so much weight, and I feel like there's such an opportunity in this to keep it from getting so political at the data level, and to keep it within the learning. And I think this is where these adaptive approaches, where we have these pilots that were talked about in multiple presentations here too, where we show that art of the possible, where we look at a very small number or even one outcome, one piece of data that can inform an ongoing decision and a set of evidence. I think when we start looking at that level of possibility within that data and the trust that we can build, we have to build trust in these small pockets to be able to show that we can build trust bigger and across the country. I think oftentimes when we start really big, that's where we see individual jurisdictions getting into these sort of political kind of ownerships. We all know data is power, information is power. And so I think when we start looking at these at the level of a registry, at the level of a group of patients, where we can start showing what this looks like in a way that takes some of the risk and uncertainty out of it, I think we're going to build more momentum there. And I think we're going to show that we can then, there is more commonality than there are differences across jurisdictions and disorders and data sets in that. So that's our biggest challenge within this is trying to use that data that represents the perspectives without putting so much onto it as well. And I think we just do that in these proofs of concepts and into this work that we're doing.
Yep. Thanks so much. We got some actually thumbs up from the clinician who was on the spotlight before. And I want to bring it back to Dr. Al-Baldawi as well, because Dr. Sadev mentioned that one of the goals of the Cancer Clinician Forum is to reduce paperwork and administrative burden on clinicians. If we require them to collect more data, I think you mentioned that can be pretty burdensome. I'm just wondering, as a relatively new doctor going through medical school, are they talking about this in terms of your residency and what you learned in med school? Is rare diseases getting the attention that it needs and deserves? And we're testing your audio again.
I'm having some trouble with my audio. I don't know if you can hear me.
No, your audio is much better.
Okay, great. You can hear me. I can't hear you though. I missed the second half of your question. I'm sorry. 1 second.
Yeah, I'm going to just say testing as you're testing your mic, because we're good.
I can hear you now. Sorry.
It was just, are rare diseases getting the attention that they need in medical school as a relatively new clinician? And so can you tell us a little bit about, I mean, were you called up to sort of help explain that? And I'm looking at Jennifer too. Like, do you get called in to do like continuing medical education to say, hey, look for the rare, don't just look for the common? I see not, but let's start with Dr. Al-Badawi.
No, I would say that's an issue. And honestly, prior to medical school, I did my master's in also investigating rare conditions, specifically like metabolic rare conditions. And there was an issue that was brought up frequently by parents and by there is a pediatric population, so there rarely any touch of that in medical school, and that's not unique across like where I went to McMaster, but that's not unique across medical schools. There's not much emphasis on rare conditions. I would say maybe like my condition, like homozygous familial hypercholesterolemia, people are more aware of lipid disorders, but the more rare kind of issues and the other kinds of are not as well looked at or taught even.
Thanks so much. And Jennifer, do you want to jump in there too?
Yeah, I would even stretch it further that we're still looking at that more holistic picture and the holistic view of Canadian healthcare. And what are we really thinking about is there enough time in that patient clinician interaction to be able to really dive into those nuanced histories and be able to expand on those things? You have to think about those probabilities. Like when you hear history, you think about probability. Well, probability is going to be this, and so it's really or is there enough time? Genetics takes and genomics have so much more of a fundamental basis of diagnosis, and we understand that so much more now. But is that being implemented? Do physicians, do clinicians have that opportunity for medical education within the healthcare system to be able to understand that and learn all that? So, as Dr. Sandy had discussed, it's more of that holistic view of Canadian healthcare and where is that coming from, and a lot of it comes back to time and pressure and the lack of family physicians, the lack of specialists, the lack of resources, all of those things that are contributing to that.
Yeah, no, thanks. Thanks, Jennifer. Mitch, having run one of the bigger public drug programs in Canada, in British Columbia, did you and your officials have a lot of interaction with the health system and leaders that are clinicians and patients? Actually, BC had the Your Voice opportunity for additional patient input, so I'll give a shout out to that opportunity. But some of the questions we're talking about, it's not just about the medicine. Did BC PharmaCare take into account some of the stuff that Rebecca and Leslie unearthed in their review of the Ipsos data?
I think those are always areas that the decision makers and particularly the people that are doing the reviews, the clinical reviews, are aware of. I mean, they look at the social economic kind of considerations as well and impacts. It's becoming more and more, I think, pronounced in HTA and other reviews, I guess. But I think the one challenge that we have, and I think going back to Jennifer's comment about, there is evidence, there's international evidence on some of these things. I think what we have to remember is that we're not trying to convince the people that we're trying to convince aren't necessarily experts in healthcare. They're people that are holding, people that are holding the purse strings and that. And that's why I think the evidence has to be there and made very visible to them so that they can say, yeah, this is I think right now in BC, the recent budget, 42% of all revenue is going towards healthcare. So you have to make those arguments and be able to demonstrate that, this is a good investment. And I think the presentations that we heard today are good, solid ways in which to do that. And more of that kind of knowledge translation, I think, is needed amongst for decision makers to talk to their political principles to actually secure funding going forward and ensure that it's sustainable.
Yeah, excellent. Thanks so much, Mitch. And I know the IHE was here at the CORD conference when it was in Ottawa most recently, and the conference did hear some preliminary data. I have to just give a shout out back to Leslie and the crew at IHE for digging deeper and then bringing forward the data with such good visualizations, because I think one of the takeaways I got was rare costs the system regardless of whether there's a treatment or not. Like 14 clinicians, 7 on average family physicians, 7 specialist physicians or clinicians, I should say, that adds up compared to the general population. I'm very fortunate to just try to see my doctor once a year, and I can't imagine how many times you're in there, Jennifer, with your kid to be able to do this. I think when we had you on the Hill, you were saying, yeah, that's nothing compared to, what some, and remember, that's the average, right? And that really came through loud and clear with all the patients that were here trying to bring that message forward at the national level, Mitch, in Ottawa a couple months ago. We're over time. I'm really fortunate to have had this panel spend so much extra time with us. Angela thank you so much to the panelists and the spotlighters. You've been terrific. I hope you're all marking Rare Disease Day in your own way. Angela and Hillary might have put in the chat. We are lighting up the country in rare disease colors at different monuments. So that's going to be happening tomorrow. And please do send or tag those pictures when you get them from the CN Tower to Niagara Falls, you name it. We are going to call up the slide. Angela, that's your cue to talk about the conference. And in fact, I'm going to pass it over for final words to Durhan. Thanks again, panelists and spotlighters. Durhan, bring us home. Thank you.
Thank you very much, but I would be remiss if I don't do two quick things. One is subject to Sandy's presentation. We do have a rare cancer now that is funded by FAST, the first rare drug, even though it's a cancer. So it does show that we can do rare within that bucket. Varangio for brain cancer. First, in terms of a brain cancer drug. So this is amazing. We also really are excited about, as you say, the opportunities in terms of where we can go with actually collecting the evidence. And, I put in the chat, HOFH already has a monitoring program. As you know, VHL also has a monitoring program. But these have been done by the clinicians and at the hospitals and not necessarily with this funding. So we know it can be done. We just need to get more of it and we get them more systematized. So thank you so much, Bill, for moderating this and taking us all through it. For everybody who's hung on with us, Rare Disease Day Conference is coming up at the end of April. We hope that, we will see all of you there and many more. It really is a great opportunity for us to stand together and say thank you for the support for the rare disease drug strategy. Thank you for helping accelerate these drugs. But guess what? We need a whole lot more, only because it's just not only good for the patients, but it's good for the rest of society. So thank you so much for being here. Happy Rare Disease Day. We will look forward to seeing you again very, very shortly.
Well, and Durhan, one last thing, maybe
Yes.
a special shout out to all of the rare disease patient advocates, especially in Ontario, who are actually visiting with their MPPs and political leaders today. It's a little constituency day that's not a little one, a big one, because rare is across the province and hopefully across the country. So if you want to learn how to advocate, get in touch with CORD, join CORD, and then get out and about because your voices matter. So yeah, thank you so much, Durhan, for being our leader on this, and we'll see you soon in Toronto. Take care.
Thank you.
Bye-bye.